So a constant theme has been the battle so many face when it comes to being diagnosed. Now, earlier in the programme, I spoke to Tanya Simon-Hall, who's so frustrated about the lack of information available about adenomyosis when she was diagnosed 2 years ago that she's launched a campaign and a petition calling for more research into the condition to be done. And we began our chat. First question, as people who do have adenomyosis do begin, I said, what are your pain levels like today?
Pain levels are good today. I got a bit of a bellyache, but that's normal for me.
Okay. When did you find out you had adenomyosis?
I was diagnosed with adenomyosis in 2021 due to really suffering at work. I was having a really, really bad time, and I thought I had endo before that, but it was never diagnosed.
Endometriosis?
Yeah, so I went to the doctor. I had the hip pain, pelvis pain, the bowling ball, heavy, the really, really vomiting, lying on the bathroom floor.
This is every time you had a period?
Yep, crying. Went to the doctor. They were like, okay, we'll send you off for a scan. They sent me for 2 scans, actually. The first one said I had adenomyosis, and then the second one said I had endometriosis. I was on my cycle. I was on my period during the scan, and I was going to take the conscious decision not to attend because of that reason, but then you would definitely be able to see that there's something wrong because this is the time when I'm experiencing the most pain. I received a call from the doctor maybe a week later. Hi, Tanya. You've got adenomyosis. There's nothing to worry about. Bye.
What do you mean nothing to... Did you ask, what is this? Had you ever heard of adenomyosis?
No, I've never had heard of it up until the point that I was told that I was diagnosed with it. And then...
So just take me through this phone call again, sorry. Hello, Tanya, you have adenomyosis.
It's nothing to worry about. Yeah, bye.
Can you just explain why it's so important to you that there should be a page on the NHS England website about adenomyosis?
For me, it's important because if you go to your employer and you say to your employer, I'm sick, and your employer says, oh, what's wrong with you? And you say, oh, I've got adenomyosis. The first place that they're actually going to go to is most probably the NHS website, and it's not there. So we're not taken seriously. It's not taken seriously. Adenomyosis as a whole, as a condition, is not taken seriously, and it's important that it's there so it's recognised by other people, not just by us that suffer. Because to live with this condition, it's not easy. Some women have no symptoms whatsoever, and some women like yourself have really, really bad symptoms. So where's the medium? Who's getting the support here? Nobody. And a lot of professionals, GPs, they don't even know what it is.
It's quite a thing to be told, isn't it? I'm in the studio now with Dr. Nagat Arif, a GP and expert in women's health. Hello.
Hi, good afternoon.
You've put stuff on social media about this for ages, absolutely ages. Do you want to should we just go through the basics? What is adenomyosis?
So adenomyosis, according to the Bristol NHS Trust, affects one...
Sorry, I didn't have your microphone up. I'm the unprofessional one in this room. What is adenomyosis? Good morning, Nagat.
Good morning. Good afternoon. So adenomyosis, we think, affects about 1 in 10 women, and that's according to the latest research from the NHS Bristol Trust. And that's only because we've started finally documenting what adenomyosis is. Essentially, it happens when the cells from the lining of the womb are found in the cell wall of the womb, and then these cells grow, they break down, and they bleed during each period, causing heavy, painful and irregular periods. And they come with a whole host of symptoms.
Okay. Why, as I was hearing from Tanya, why does it take so long to get a diagnosis?
One, because I think people don't know that it exists. We know about endometriosis, which are cells similar to the lining of the womb that grow outside into the pelvis, but actually people don't know that there are cells which can go into the muscular wall of the womb. And then the symptoms overlap with so many other conditions. So the symptoms are heavy, painful, irregular periods, premenstrual pelvic pain. You can get heaviness and discomfort in the pelvis. You can even get increased urinary frequency, painful on intercourse, and not just sometimes superficial intercourse, deep intercourse, and actually pain after having intercourse as well. And then painful having a poo. And you almost feel a heaviness or a bloating within your pelvis. Now, that can get mixed up with, say, irritable bowel syndrome. It can get mixed up with, say, if you're a woman of a certain age, ovarian cancer. It can get mixed up with constipation. It can get mixed up with just fibroids or endometriosis. And because these symptoms are so hodgepodge, it means that joining up the dots can be quite tricky. And also, the biggest thing is we don't have a test for it. So you can't see it on an ultrasound scan. There's no blood test that we can do to find it. And up until recently, we didn't actually have a way of coding it on our system. So most doctors who are listening, and as an NHS GP, we use a system called EMIS. There's lots of different ones. There's System 1, etc. And that is a way of logging all our medical notes for our patients. And we didn't have a code for adenomyosis. We do now, and that I would say came around in the last 5-6 months or so. That in my
only in the last 5 or 6 months.
Yeah, that in my last surgery, that if I had a patient who was diagnosed with, say, adenomyosis, I can now type in uterine adenomyosis. Now, the significance of that is once you start coding a patient on their medical notes, we can then work out the numbers of how many women are affected, women of different ethnicities, and also how long it took us to even get the diagnosis for these women.
Had a text from Dr. Andrew Curfey, he's an NHS GP, saying this. Quite right about GPs not knowing what to do. Agatha, I'll explain that we were having many experiences of GPs who just didn't know about it. Tanya herself was told you got adenomyosis by. That was it, nothing offered. So Dr. Curfey says, quite right about GPs not knowing what to do. We have not had much education or support on it to help women affected by the condition. I get back ultrasound reports saying there is adenomyosis and advising on referral. I refer to a gynaecologist, hoping they'll assess my patient, but just get limited and scant advice back. I Google it for professional guidelines. There's next to not a lot out there. I only end up being frustrated with my patient. It's one of these issues I feel has been ignored for years.
And absolutely. It's only in the last year or so that I've been talking about it, but that's because of years of clinical knowledge. I've been a doctor now for 15 years working in the NHS, and then picking up these hodgepodge symptoms and then realising, reflecting on my patients. Currently, we don't have an NHS. From the core NHS Digital website, NHS Digital, we don't have a page on adenomyosis. We have
for NHS England.
For NHS England.
In Scotland, yeah.
Yes, of course, it is in Scotland. And we don't actually have guidance at all. We don't have any modules which are related to, in regards to how we learn about it from the RCGP. And then currently also the treatment for adenomyosis falls under heavy menstrual bleeding or HMB guidelines from...
HMB.
Heavy menstrual bleeding in regards to how we manage it. So essentially the management is, well, if a woman has heavy painful periods, then treat her rather than investigating properly and then trying to form an actual management plan. So essentially, women who come in going with heavy menstrual periods, we put them on mefenamic acid, which are medicines to reduce flow, or tranexamic acid, which also reduces flow as well, or we put them on the contraceptive pill to stop their periods somehow. Either that could be the mini pill, the injection, or a Mirena coil. Still not really understanding the underlying diagnosis of adenomyosis. So it can take years and years and years of women just being left in the healthcare system in primary care to put up with them, because there is no clear guidance at the moment, and we are working on trying to improve that.
Also, how do you know if you are bleeding more heavily than usual? You know, a simple thing, you know, only thing I knew is when I'd say to my mates, or, you know, who I started at 16 later than most of my friends, just because they hadn't told me they were going through this, they weren't. How do you know yours isn't normal? Yours isn't an acceptable amount of pain?
That is such a good question, because I often find that everybody's normal is different. And also, if we tell each other, well, actually, I go through maybe a sanitary towel every 3 hours, because somebody who goes, no, I go through a heavy flow pad or tampon every half an hour, then that would be the distinction. And we don't talk to our friends about it.
I've never been asked by my GP, or never was when I was younger, how often I had to change my sanitary
And
wear.
this stems back to the fact that when it comes to women's health education as a whole, this is the Women's Health Strategy data that shows that doctors aren't taught about women's health appropriately, and they aren't asking even the basic questions of pain levels and how often are you changing your sanitary pads? Is it painful to have sex? We don't ask about that. Are you going more frequently in and around your cycle. Nausea and vomiting, how often is that happening to you in and around your cycle? A quick tip to know if you're bleeding really heavily is I go by, because there is actually how much tablespoons. Now, nobody weighs out tablespoons and measures tablespoons of blood
I can
flow.
tell anyone right now, if you've not had a period, if you have a period, the last thing you're going to do is start
Exactly.
getting a teaspoon or a tablespoon out to figure out how much you're bleeding.
So I go by sanitary towels because I, as a woman, bleed as well, and I need to know what's heavy and what's not. And so I think that my sort of clinical judgment has been, look, if you're changing a heavy flow sanitary pad or a towel every half an hour to an hour, that's heavy flow, especially if you're then flooding on top of that. So I've had patients who come in and say to me, I'm using the heaviest flow, and on top of that, I'm using a sanitary pad and I'm flooding through. That is not normal. That needs to be investigated. Please don't put a woman on contraceptive pill and say to her, that'll stem it, or tranexamic acid and send her home. That needs to be investigated.
Okay, how do we help ourselves in this sense? Because at this moment in time, there is no clear guidance about adenomyosis on the NHS website, and you cannot guarantee. Although, women may be fortunate to have, I feel grateful for your female clients, but we don't all have GPs that are educated or know enough about this. What can we do for ourselves? What can we do more?
So firstly, I'm so proud of you for opening this conversation up, because I think this is exactly what we need. We need women to unashamedly, unabashedly talk about their periods and their pain levels as well. And it's not because you have to, forgive me for saying this, but man up or, better put up with it. So that's number one. And secondly, we learn from our patients. The biggest thing is I say that my patients' lived-in experience will always affect my guidance more than any textbooks will. The other thing is then when it comes to, say, colleges, so from the RCOG, so the Royal College of Obstetrics and Gynecology, the Royal College of GPs, we need to be looking at how we're delivering women's health care from the basic at medical school all the way through into our training as well. And then the other thing is that when we come across new conditions, we need to be putting in the funding and the research as well. So we need to be looking into how can we actually get the diagnosis. Yes, you can see it on an ultrasound scan, but usually it's advanced adenomyosis. We should be able to pick it up earlier because a woman is on her journey. She might want children. She might want to plan her life. She might want to have a career, and we're not thinking about that in any shape or form at the moment. So we need tests to say that these are good and valid enough to give us the diagnosis, and then consultants to be able to give a treatment, because at the moment the only treatment is a hysterectomy.
Yes, and I was also told that the only way to 100% know you've got adenomyosis is when your uterus is removed.
Yeah.
And it can't be put back, obviously.
Obviously. And that is so sad, because actually every woman is on a journey of where she wants to be in regards to her fertility years. And I get a lot of patients who their only offer is a hysterectomy, and they grieve. I mean, a woman come back, and yes, it means that they get their life back in some way, that they're not in pain every day. But there is a sense of loss and grief that they go through in regards to that this is final and the end of it. And surely that shouldn't be the case, because that shows that medical research and medical care has failed, that the only way to deal with something is take out an organ. And what we are trying to do at the Women's Wellbeing of Women and the Women's Health Strategy is hopefully trying to improve all the research. So the Wellbeing of Women is a charity which is really looking at funding and research that's going into adenomyosis, but also what ethnic minority communities support that they can have. So there's patients who just have to know their body really, really well, track your periods, keep a symptom diary, keep going back to the doctor. And then we at a research and college level have to improve our education as well. That's the things that we can do.
Professor Camilla Hawthorne, chair of the Royal College of GPs, says GPs take women's health very seriously. However, because of the significant variation in severity of symptoms of adenomyosis, some cases can be hard for us to detect. And so we would certainly welcome more research and greater awareness into the cause of adenomyosis, as well as more treatment and management options to help women. They'd welcome it. Who's doing it?
No, my colleagues are doing it. I'm an NHS GP, and I'm telling you that we are delivering the best care that we possibly can do. We're working in extremely difficult circumstances. And in the NHS, I have 10 minutes with my patients. And that means that if most of my patients are listening at the moment, they'll know I'm constantly running late. So I'm really sorry about that. But there is a time capacity, there's joining up the dots, there's understanding the knowledge, going on courses. And I feel that when I look around at my colleagues, the general consensus is, yes, we don't know about adenomyosis, but so many of my colleagues will actively go out of their own time on weekends, on evenings, to webinars to learn about this. And also because somebody like me puts in their free hours to produce content, educational content across my social media that my colleagues will learn from. This is the pattern that we do, because we are working doctors, but also trying to learn in our free time, whichever little free time that we have, and from colleagues as well. It's a partnership.
I know your book. It looks beautiful, by the way. The knowledge. This is your guide. It's written by you, obviously, Nagat. Your guide to female health from menstruation to menopause. This kind of goes back to what you were saying about we need to talk about this a lot more. It never needs to be taboo. It needs to be openly spoken about with bosses, with colleagues, with anyone, really. Not just, let me tell you about my period. That's not what I'm saying. It's just, let's make people aware. And the only way we can make people aware is by knowing ourselves as well.
So the book came about after years of my own clinical knowledge. And when I was younger, talking about your boobs or your vaginas or your vulvas was such a taboo because everything is hypersexualized in our society. I come from a conservative Muslim Pakistani background, but I was doing this in my clinics. And I thought, actually, what we need is something that is representative. So I've got vulvas and vaginas of women of color. It's got the first picture of lichen sclerosis of women in colour and what vaginal atrophy really looks like. So it starts with puberty years, goes through the fertility years, and then on to menopause. And it's written in a style which is non-jargon. Any 12-year-old can pick it up. And there's sections for dads, LGBTQ+, etc., communities as well, who suddenly, sadly, do get missed when it comes to healthcare, particularly around periods. And the thing I find is that when we have knowledge, we should never try and keep it to us. We should sprinkle it around like confetti because other people learn from you. So this is really a labour of love of 10 years. It took me a year and a half to write, to get all the illustrations in. I've had an incredible team who've helped me to put this together. And I just hope that people look at it and feel it can go on my coffee side table and I'm not going to be embarrassed. And what I learned from this, I will share. Because the most amazing thing in my consulting room is that if I share a nugget about an adenomyosis or fibroids, that woman guaranteed will go home and share it with all her mates. And I love that.
Absolutely, we do talk. Can diet help? Someone's asking. Adenomyosis. When I was talking to Tanya, actually, she was saying that she's changed various parts of her diet. My wife's endometriosis has improved after eating a whole food, plant-based diet.
So there is some emerging data to show that better care when it comes to your gut microbiome can help in regards to pain, etc. We do also have, we know a third of our immune system lives in our gut as well, which is very close to our womb. So looking at how you can eat healthier, obviously maintaining a good healthy weight is really good, but we need to get better control and understanding of pain per se.
Sally in Derbyshire, one more for you. Hi Naga, I was diagnosed with adenomyosis and endometriosis in 2021 following several years of excruciating pain and unpredictable and heavy periods. I was referred to a consultant gynaecologist, given a total hysterectomy in January this year. I feel so much better. No pain, no bleeding and more energy. I'm 47, so I'm now on estradiol, thank you, because my ovaries have been removed as part of the procedure, but I do feel so much better as a result. I was lucky to find a consultant who understood and acted to help me. I'm so pleased for Sally that's worked out, but I've made very clear, and there are others like me who don't want a hysterectomy, which is why these conversations need to be, and these treatments need to be explored further.
Yeah, so we need to be looking at treatments such as UAE. We need to also look at embolization. We need to look at ablation as well. And it's that woman on her trajectory of where she is. Because if a younger woman, say she's in her 20s and 30s and suffering horrifically with adenomyosis, you offer a hysterectomy, well, where does that leave her in regards to planning her family? She might have dreamed of a family all the time. And what about the sort of care for women around perimenopausal age? So these are women who are having irregular, maybe heavy periods, but then transitioning into perimenopause and menopause, which is 1 year without a cycle. So we are leaving these women for about maybe even a decade in the perimenopausal phase in regards to their symptoms. And I think that this is where we need to not just think of women as I would say that we think of women as boobs and wombs. Well, we can't think of them just like that. We've got to think of them in a more holistic manner, but also women who are cyclical beings who are also then going to be transitioning from, say, their fertility years to their menopausal years, which is what I've covered quite a lot in my book, because I don't think we can be seeing as women as just, oh, well, she's just going to get pregnant at this stage in her life, but forget the fact that we need to prepare her in her 20s and 30s for the perimenopausal years as well.
It's always a joy talking to you.
Oh.
Thank you so much for coming. Good luck with the book. It's out in August, isn't it? It's called The Knowledge. August?
August the 3rd, and I'll be at the Hay Festival this Friday talking about it.
Well, Nihal's there as well, so it's something that we're very familiar with here on 5 Live. Dr. Nagat Arif, thank you.
Thank you.